Good evening. My name is Dr. Srihari Naidu. I'm president-elect for the New York State Chapter of the American College of Cardiology. Thank you for joining us on this first in a new series in New York ACC called Aftershocks. So Aftershocks is our attempt to try to get leading experts from around the country paired with moderators locally in New York who are themselves integral to the field in which they're talking about, and to really look at the major trials that are coming out of the major meetings. So we're going to do one or two after every major meeting, starting first with HRS, then moving on to HFSA, TCT, AHA, ACE, ACC, SCI, and so on. And the idea is to get our members to talk to each other from across the aisle, people from EP to interventional cardiology to heart failure to non-invasive and other areas within cardiology, both academic and prior practice, and allow us to have bite-sized discussions of the leading trials that have come out so that we can very quickly understand what came out at a meeting that we may or may not have gone to, especially now in virtual era, and also what are the key takeaway points, and to hear from really experts in that field. So without further ado, I'd like to introduce the moderator for this evening's session, Dr. Suneet Mittal, who is a very good friend of mine. He lives in New York and works at Valley Hospital as the Director of Electrophysiology and the Associate Chair of Cardiology for Valley Hospital Cardiovascular Services. And he's going to introduce our key speaker tonight about a trial that came out at HRS about a week ago, and he'll take it away from there. Suneet?
Hari, thanks very much. And I want to thank you and Dr. Vidula for really this exciting initiative. And I look forward to this being the first of many exciting aftershock discussions. Tonight, I have the privilege of joining my dear friend, DJ Lacaretti. DJ is the Executive Medical Director of the Kansas City Heart Rhythm Institute at HCA Midwest in Overland Park, Kansas. He's also Professor of Medicine at the University of Missouri. But more importantly, DJ is, without question, one of the thought leaders in electrophysiology, having pioneered a number of innovative procedures and having published a number of seminal articles. Additionally, DJ and I have the privilege currently of serving on the Heart Rhythm Society Board of Trustees. Last week was an exciting time for the electrophysiology community as we had our first in-person meeting since the start of the COVID-19 pandemic, and it was the annual Heart Rhythm Society's annual scientific sessions, which were held in Boston. At that meeting, DJ presented a very exciting study called the Stroke VT study, which was chosen as one of the top late-breaking clinical trials presentations for this year's meeting. And this study has now been published online in the Journal of the American College of Cardiology, Electrophysiology. So tonight, we're going to spend a few minutes with DJ to talk about this study. So first and foremost, welcome, DJ.
Thank you, Suneet. Thanks for the opportunity. The title of this session is amazing. When I first heard about it, it really makes a lot of sense, right? So there's a lot of things that come out after a major late-breaking clinical trial. So looking forward to it.
Yeah. So DJ, before we get into the actual results of Stroke VT, you know, randomized clinical trials don't just occur in a vacuum. Investigators have to first think about a question that's relevant to clinical practice, and they go about designing a study. This was particularly innovative because it involved investigators not only in the United States as well as in India. So take us a little bit to the genesis of the study, what the question you are trying to answer, and really how the study was designed to answer that question.
So Suneet, anytime, I mean, you know this, we do ablations on the left side of the heart, either it's in the left atrium or the left ventricle, which is in communication with systemic circulation. There is always a possibility of systemic thromboembolic events happening. And we have noticed it and proven it beyond doubt through the work that has happened in the atrial fibrillation space when we had initially had not considered doing ablations on therapeutic anticoagulation or sending patients home on anticoagulation. And over a period of 5 to 10 years, we all figured out that the risk of embolic events and strokes could be dramatically reduced by anticoagulating these people peri-procedurally and most importantly, post-procedurally. And that kind of opened up conversations on many levels with regards to the VT. But the adaptation of a rigorous anticoagulation protocol after ablations in the left ventricle has not been as consistent because there was no guideline, there was no major trial that actually could help people to really understand that. And so there was a tremendous amount of heterogeneity in how people handled post-ablation anticoagulation or antiplatelet therapy after a PVC ablation or a VT ablation or something else. So for lack of a better strategy, this question needed to be answered once for all and put to rest, right? I mean, we all kind of empirically adapted oral anticoagulation and we did it, but then there are many other individuals that didn't do that. And then especially in a PVC ablation, people who are a lot more relaxed about not starting them an anticoagulation. So this really opened up that particular question. Can we systematically study this? And especially with the advent of direct oral anticoagulants, doing this study became relatively straightforward, unlike the olden days of warfarin, where you had to hold warfarin for so long and getting them back to therapeutic anticoagulation became problematic. So this really became relatively easy with DOACs readily available. And that's kind of the genesis of this, so that we could once for all answer this question and really see if a post-procedural anticoagulation regimen for 4 weeks is a reasonable option in minimizing the risk of stroke and TIAs and asymptomatic cerebral embolizations in these people.
Great. So I think that that's really very novel because, as you mentioned, uninterrupted anticoagulation has become the norm for atrial fibrillation, but remarkably, VT ablation has been growing in its use across the world. So without question, this is a very important question for us to know. With stroke being the endpoint, the clinical ramifications here are huge. So take us a little bit through just the very basic inclusion and exclusion criteria and the design of this study.
Sure. Any patient that is not exposed to oral anticoagulation, i.e., they don't have prior history of atrial fibrillation or need for continued oral anticoagulation, either a mechanical valve or a deep vein thrombosis, undergoing a left ventricular ablation, either a PVC or a scar ventricular tachycardia, either related to ischemic cardiomyopathy or non-ischemic cardiomyopathy, are included. We obviously excluded patients that have contraindications for oral anticoagulation and patients who you will not be able to follow up, patients who are terminally ill. Those are all cases that we excluded. So what this ended up being is anybody that is not exposed to oral anticoagulation that needed a left ventricular ablation, either for a PVC or VT, ended up being considered for this particular trial.
DJ, did you have any challenges in recruitment, or was this a relatively easy study to recruit for?
Oh, this study really literally took us 4 years, right? That just goes to tell you, for 243 patients, 46 patients, it took us 4 years. So I mean, anytime you have an investigator-initiated idea that doesn't have millions of dollars funding, it's always hard to recruit. And again, the rigorousness with which you have to follow these patients is definitely, something to take into consideration. So was it easy to recruit? Yes, it was not. But at the same time, I think when you really propose the study idea and then you have committed researchers, I think we get stuff done, right? So that was kind of where we are on that.
Yeah. DJ, Hari is a well-known interventionalist, and we're taught that really these strokes are nothing more than aortic pathology. And I was taught in my training, well, if you're worried about stroke, just do a transeptal approach to the left ventricle and you'll be okay. So are you finding something beyond that, or can I just eliminate the stroke risk by doing transeptal approaches to the left ventricle?
Suneet, it's a terrific question, right? So this is an age-old question that we all ask: is transaortic approach more riskier than transeptal approach? Can you completely eliminate strokes by using merely transeptal approach? So we actually asked that question, and so we allowed people to use retrograde aortic approach if they are comfortable with it, if they felt that it was necessary. what we find was in line with the interventional data, right? This is sort of what our interventional colleagues taught us for many, many years, right? When you invade an aorta that is filled with plaque and you're manipulating stuff inside the aortic root, you are bound to flake off some of the plaque, and then you would end up with both symptomatic and asymptomatic embolic events. We did find that in those group of people where the retrograde aortic approach has been used for left ventricular ablation, the risk of both symptomatic and asymptomatic cerebral embolic events was significantly higher than it is with the transeptal approach. But that didn't mean that the strokes or TIAs or asymptomatic cerebral embolizations in the transeptal group of people was zero. We still had events happen in that. Because when you think about it, I think there is more than aortic plaque displacement here. When we ablate the ventricular myocardium, you are targeting a relatively larger amount of myocardium, and when you're sweeping across the swaths of ventricular tachycardia substrate, there's a significant shift towards substrate modification as an important strategy to maximize therapeutic solutions for these ventricular tachycardia patients. You ablate a larger amount of myocardium at higher powers. There is a higher risk of steam pops. And also, we had to remember, a lot of these patients have significantly lower left ventricular ejection fraction. So there is both a global hypokinesis where there is stasis of blood, and also segments of myocardium become hypokinetic or akinetic due to stunning. And the subsequent endothelial sort of denudation, char formation, despite using irrigated catheters, these are all factors that really play a big role into this process. And so, I mean, even in the practice of EP, we moved from ACTs of 250 to more like 300, and now a lot of us have adapted 350 as a cutoff, right, as a standard in VT ablations, and that is for these number of reasons. So to summarize that, yes, if you have an opportunity to avoid a retrograde aortic approach, I think that's the best case scenario. But even with transeptal approach, your risk is not zero. And so aggressive or more appropriate intra-procedural and post-procedural oral anticoagulation for a considerable period of time could dramatically help us to mitigate this risk.
Now, DJ, you've mentioned several times this issue about assessing for TIAs and stroke, which makes obviously a lot of sense, but you've also talked about getting MRIs on individuals. So for the non-electrophysiologists who may be hearing, it may not be so obvious why we need to get MRIs in people who may otherwise be asymptomatic. Could you tell us a little bit about the importance of that as an endpoint and the potential clinical significance?
Yes, Suneet. So symptom is a manifestation of a portion of the brain that has the ability to express itself right away, right? So for example, there are critical portions of the brain that are obviously manifest, like if it affects the speech zone, so somebody's going to become aphasic or dysphasic. If it affects the motor region, they're going to have motor symptoms. If they affect the cerebellum, they're going to have balance issues. If it goes into the ocular circulation, they're going to have, or the occipital lobe, they're going to have visual issues. But there is a large amount of brain tissue which can have a long-term effect on our overall neurological performance, but it may not manifest itself in immediate stroke manifestation. I think when you are showering off a bunch of emboli into the systemic circulation, these can land in multiple locations, and some may land in areas that are critical, and some may land in areas that are subcritical and or may not be manifest right away, right? And the only way we would be able to see these things is by doing an MRI scan. And unfortunately, we really don't know a whole lot about what happens to this, right? So long-term follow-up studies that are mostly based off of our AFib studies, we found that a lot of these asymptomatic cerebral embolizations actually improve over a period of time, right? And then they disappear. So does it mean that whatever transient effect that we had or a transient impact that there was on the brain, which was asymptomatic, has completely recovered itself and we are back to baseline? There are very few studies that actually looked at the long-term neurocognitive impact of these type of lesions, there is early evidence to suggest that these lesions may not be as benign as we think that they are, right? There may be some implications to that. And that is the reason why doing MRI scans in these people becomes important. And that kind of became sort of one way of taking away the limited bias or the limited effectiveness of symptoms alone, right? So that's the reason why these asymptomatic cerebral embolizations really become a measuring stick to really assess the impact of embolic events in these type of situations.
Absolutely. And I congratulate you and your investigators for taking the step to go beyond the clinical symptoms to really understand this issue. Well, with that background in mind, why don't we review the results of the trial? I understand you have a slide that summarizes the main findings. Why don't we have you take us through the main findings of this randomized clinical trial?
Absolutely, Suneet. Do you see it?
I think it's coming up now. There we go.
So the left side of the screen basically shows a typical VT ablation where you have a posterior basal scar. What you see here is after the appropriate clinical circuit was ablated, there was a significant amount of homogenization. Again, this approach has clearly yielded amazing results in terms of improving the longevity of the radiofrequency ablation outcomes and mitigating the need for repeated ablation. So this is kind of the current prevailing strategy. On the right side, you have an example of these asymptomatic embolic events, sort of these punctate demyelinated lesions that you see, suggestive of the asymptomatic embolic events. So the area below that is the study population. You have 246 patients that were randomized to direct oral anticoagulation and aspirin. And the main findings, obviously, are the transient ischemic attacks were in the range of 17.9% in the aspirin group and 4.9% in the DOAC group. This was a question that was brought up by many people, that why the incidence of these TIAs that you see here were significantly higher in our study than it was with the previous studies. So I think one of the things we had to realize is, number one, there was no randomized controlled trial ever done on this particular topic. And when you look at studies like the studies that were done previously, a lot of these studies actually had patients placed on oral anticoagulation, right? And most of the data that we have on this particular topic is mostly retrospective studies or observational studies. And what we also have to realize is these are patients that had rigorous follow-up with research staff calling them on a weekly basis, trying to find out if they had vision changes, if they had motor changes, if they had balance changes, right? So when you really look at a TIA, TIA has a very broader definition. So based on that, I could say maybe we were overcalling it a little bit, but a symptom is a symptom. And when a patient reports it, and if it meets the criteria that you have pre-specified and predefined, I think we need to take that into consideration. And so that is kind of one of the reasons why the more we looked, the more we found, right? So in a traditional setting, in most of the studies, the way you followed outcomes is the patient goes home, and then they get a follow-up phone call in a week, and then maybe they get a follow-up phone call in a month, right? And then if the patient was not asked, they're not going to report it, and they're going to forget about it, and with everything that goes on. So that may be one reason why we have a strikingly higher number of TIA events, but it is what it is, and we would like to see if there could be something different about it. And then the strokes were, we were able to completely mitigate the risk of stroke by anticoagulating these people. So the post-procedural stroke risk was 0 with DOACs and 6.5% with the aspirin. And then when you looked at the asymptomatic cerebral embolizations, this is pretty striking and very much consistent with the AFib ablation data and the previously published single-arm VT and PVC ablation data. So we were able to significantly reduce these asymptomatic embolic events by using DOACs, right, from 22.8% to 12.2%. Again, in the long term, these events were not completely zero. You will notice that in the aspirin arm, you still had a persistently higher number of these asymptomatic embolic events. they came down to about 6.3%, clearly suggesting that there is a role for appropriate oral anticoagulation and keeping their blood thin. This would be very helpful. When we looked at multivariate analysis to really understand the predictors of these embolic events, significantly longer ablation times, retrograde aortic access, low left ventricular ejection fraction, and obviously the aspirin used were predictors of this. So I think based on this randomized controlled trial, while it is small, but it still has a very significant impact on the outcomes that we looked at, it is safe to say that post-procedural DOAC use significantly reduces the risk of stroke, TIAs, but also asymptomatic cerebral embolizations after left ventricular ablations. I think this has a potential to really change people's practices, and hopefully we can take away the heterogeneity that exists in post-procedural care for these patients.
DJ, thanks so much for that wonderful summary. You know, for me, I had been trying to avoid retrograde access, but it was humbling to see how much benefit is still there with the DOACs. And I know this is the kind of a study that changes and informs practice right away. I know we came back from HRS and spoke as a group, but that we would uniformly be using DOACs for some period of time after these procedures, because you're awakened, you know, to the potential, you know, adverse significance that is here. So again, congratulations on this outstanding study. Thank you for sharing it with our audience. And I'm going to turn it over to Dr. Naidu for some final concluding comments.
Thank you.
Yes, fabulous presentation, great data. I think we do a lot of VT ablations as well. I think one question before I end this and hand this over to Hima also for a few, Dr. Padula for a few comments, is we do a lot of our VT ablations, especially the very low EF with mechanical circulatory support. So in those patients that needed that, did you see an uptick in bleeding, or how did you handle the first 24 hours of transitioning to blood thinners in these patients?
So the number of patients that needed hemodynamic support, or where we used hemodynamic support, was relatively smaller. And I mean, that is definitely an issue, right? In those cases where we know that we had placed them on continued intravenous heparin while they had the hemodynamic support, we delayed the initiation of the DOAC until we had secured the groin access and then that they were stable. In a lot of our cases, we actually took out the impeller, which was the primary device that we used for hemodynamic support, immediately after the procedure if they were hemodynamically stable and there was no evidence of cardiac compromise. So in those cases, we reversed them on a timely fashion and got them started on DOAC as per protocol.
I'm going to ask one question, which leads into Dr. Padula, because she is a heart failure expert. That question is that, you know, as you go from 24 to 30 days, you start thinking about the old literature about anticoagulation in patients with low EF. And we have a wealth of information, at least observational, that didn't seem to improve outcomes in terms of thromboembolic events. Was this sort of more timed with the procedure and then you wean it off? Or is it something that you think we may rediscover that with novel anticoagulants, we may have a benefit? Maybe you can comment, and then Dr. Padula, if you can comment on that and maybe close the session for us.
So my take on it is, I think this is mostly the post-procedural impact or the ablation impact on the increased risk of embolic events. And that's a question I always ask myself, right? So in this extremely low ejection fraction with patients of 15 to 20% EF or 10% EF, can you really change their overall risk of embolic events by chronic anticoagulation? And funny enough, a lot of these patients have other comorbidities, including atrial fibrillation. We find a lot of these patients on systemic anticoagulation. So I think it's a fascinating question to really think about doing a randomized controlled trial in patients with extremely low ejection fraction with no other indication for oral anticoagulation. Can you change the risk of stroke and embolic events? And I would bet we should definitely do an MRI scan in these people to really detect the risk of asymptomatic embolic events, because that's the way we could actually see the real difference.
Dr. Padula is our president, current president of New York Chapter ACC. Some final comments maybe on that question?
I agree, Dr. Lacaretti. I think we need more data on this topic. And I want to congratulate you on the completion of your study. So thank you, Dr. Mittal and Dr. Lakkireddy, for really a very thought-provoking conversation. And we really appreciate you taking the time to share your work with the New York ACC. Our next Aftershocks event will be moderated by Dr. Jim Chung and will feature Dr. Rod Tung. And following that, we will be highlighting science from the Heart Failure Society of America. So have a great night, everyone. And thank you so much for joining us.
Thank you very much. Good evening, all.
Everybody.